So let's start with today's game. Now, this is the first image. We have discussed it though. You are told to answer about the muscles of A and B. Then they are asking you. So they are showing you the muscles shown in image A and B, and they are asking you the boundaries of this scan, and then again they have given you endoscopy image of your larynx basically, and they are asking what is this image showing to you. Okay, so for this, let's start with the first one. Can I have the answer from anybody who wants to try? What is the answer of this A and B? Lateral cricoarytenoid, right? And what is B?
Thyroarytenoid.
Thyroarytenoid. Okay, so both of them are important for your exam. Okay, thyroarytenoid is very commonly asked. You all know the importance of thyroarytenoid. Okay, so over here only the other questions where the muscles are asked like this are. So you have to read muscles of mastication, muscles of tongue, muscles of neck. Okay, 1, 2, 3, and larynx. So you have seen over here. Okay, and apart from that, structures attached to mastoid process 1, and similarly to styloid process. Okay, so please go through it. This is important. Now, coming to this coming to this CT scan image. So basically, they are asking you some image of what if this area which is being marked as. So as far as like it seems to me as parapharyngeal space only. Like if I would have been there, so I would have answered it as parapharyngeal space, because they are asking the boundaries also. So generally, like a subset question. Generally, a subset question is there only when the important things are there. Okay, like the parapharyngeal space for us is, I'll say ki deep neck space infection mein, this is one of the most important space to be remembered. So over here only, I'll just write deep neck space infection. Guys, this is very important. Okay, like many a times it has been shared, so there's no point repeating it every time again. Just go back again and revise it. All in terms of its anatomy, that is its boundaries, its compartments, pre-styloid, post-styloid, okay, and what are the contents. It is important. Same goes for your retropharyngeal. 2. Third will be your Ludwig's. Okay. These are the 3 questions that you should be ready to answer from this section. There is not a point कि आप ये कि you Okay. So it's not a fact that you learn this particular scan and like ratify it. So it's not necessary that they'll ask this particular scan, but they are definitely gonna ask you one scan. Okay. So you should be ready कि इससे नहीं पूछा है तो इससे पूछेंगे. These are the 3-4 options that is available to the examiner. It's not necessary that they will ask thyroarytenoid again, but they will ask some of the other issues again. Now coming to the third thing, they have given you a long list of things. 45-year-old woman came with complaints of hoarseness, episodic dyspnea, dysphagia, and cough. Laryngoscopic appearance reveals edema, erythema, multiple irregular ulcers with, अब आता है important चीज, turban like thickening of laryngeal inlet. यहाँ पे आंसर क्या हो जाएगा?
TB larynx.
नहीं, this is a mistake which most of us make. The answer is sarcoidosis. ठीक है? So please remember it. Though TB is very important to us, जो tubercular otitis media है, tubercular larynx है, But जो turban like appearance, this specific thing which they mentioned, this is given in your Lalwani. They have shared the image along with the context with you guys. You can just check on that again. The answer is sarcoidosis. TB laryngitis में there is like non-specific findings ही दिया हुआ है ऊपर वाले तरीके है. Edema, erythema, irregular margins, all those things. But this turban-like appearance specifically they mention in the case of sarcoidosis. In sarcoidosis, one more thing is very specifically associated by the name of apple jelly nodules. This is seen in nose. ठीक है, तो दो क्वेश्चन आपके एसोसिएटेड रहते हैं सार्कोइडोसिस से. ओके, दे माइट इवन आस्क यू कि सार्कोइडोसिस के वर्कअप के लिए व्हाट यू विल डू. यू विल डू सी एंका एंड पी एंका फॉर सार्कोइड. दैट इज फॉर वैगनर्स. आई एम सॉरी दैट फॉर वैगनर्स. ठीक है, कमिंग टू द ब्रदर ऑफ दिस क्वेश्चन, same year, last year's question. A 55-year-old man underwent resection of left buccal mucosa, squamous cell carcinoma. The flap here if depicted. Identify the flap. I have the answer from anybody.
Nasolabial.
ठीक है, so it is a easy go answer, nasolabial flap. Okay, now again coming to this, what are the types of flap? Can somebody take a try? This is a anybody? Which type of flap?
Local flap.
Local or axial pattern flap. ठीक है. Now coming to the third part, that is name the artery supplying the flap shown. See, what I got in literature is that this type of flap is either superiorly based or inferiorly based. So looking at this image, we can say that this is inferiorly based. Looking at this, like no specific conclusion can be made out of it. So both the answers I am telling you. Okay? So for superiorly based flap, superiorly based nasolabial flap, the supply is branches of your angular artery. Okay, and for the inferiorly based flap, the answer is branches of facial artery. Okay, so but like suppose this comes in exam and you don't know anything what to answer. ठीक है, तो if you have to answer only one thing, answer facial artery because it's more important, more commonly seen, and if you remember then answer both of them. Let the examiner give you 1 mark for this. Okay, now coming to uses of this flap. Okay, so basically it is used in the कहाँ पे होगा, recon of the nearby structures. What are the nearby structures for this nasolabial area? Recon of nasal buccal defect, nasal defect or buccal defect, eyelids, cheek. Okay, anything else? मोटा मोटा इतना ही है. ठीक है, और lips, all those defect they mention. So ये भी आपने बता दिया. Fifth, what is the blood supply of DP flap? Now some who will tell me what is the blood supply of DP flap, and one bonus question along with that. Try. Yes, these are the branches of your internal mammary artery. Then also from your thoracoacromial artery and also from musculocutaneous arteries also. But ये दोनों तो लिखना ही लिखना है. Now another bonus question, what is the other name of DP flap?
Bica-mesan flap.
Yes, this is Bica-mesan flap. Spelling एक बार देख लेना. If this should be the answer, but this is based on my distant memory. ठीक है, which is almost 5 years old now. ठीक है, so please see this answer ना, Bica-mesan flap. Okay, now coming to this. Now, what is the name of this flap? This is not a question asked till now, but very potential question. Answer of this flap, name of this flap?
Rintala flap.
Yes, the answer is Rintala flap. Lovely. Now coming to one more named flap, which is commonly asked, again from R.
Rhomboid flap.
Yes, this is rhomboid flap. You're absolutely correct. Okay, so please go through all these. Basically, 3 flaps are important for us: PMMC, TP, and latissimus dorsi flap. Okay, so but abhi since the theory things are over, so it's not that you don't have to ratify कि PMMC में marking कहाँ पे होती है and how to elevate it and all those things. Answer तुमसे यही पूछेंगे, identify करो. You have to identify the flap. You have to tell what is the blood supply of that artery, and you should know what type of flap is there. and use of this flap. बस इससे ज़्यादा और like you don't have to remember it in full depth. Okay, so like you saw a DP flap over here, है ना? 2 point पढ़ा, artery पढ़ा. After the class, just Google 2-3 images of DP flap. Okay, like tube flap कैसे कैसे करके इसके changes कर रहे हैं. Okay. Now coming to this question, third thing, they are giving you some clinical scenario that 25-year-old male came with history of RTA with panfacial fractures. The CT reveals panfacial fractures. He has been planned for surgical repair of his panfacial fractures. Identify the approach 1 and 2, and for what fractures are these approaches used? Can somebody would like to take a try? What is 1 and 2, or shall I answer it?
One is Gillies up.
Yes, one is Gillies. Now this region is called as temporal. Full name is Gillies temporal approach. Now second one, can somebody take a try? This is Dr. Chaitra, I couldn't hear you. Please try once again.
So zygomatic bone fracture.
This is the answer for the second part. That these approaches are used for reduction of the fracture of zygomatic arch. Now, what is the name of this approach? Second wala. Okay. So, are you all keen on getting the answer? Are you all keen on getting the answer? So, the answer for this approach is Keen approach. Okay. And since it's an intraoral approach, इसको बोलते हैं transoral Keen approach. Okay, so please don't forget it till 25th. This might come as a question or some part of your question. Okay, so after this, there is a repetition of the previous class. Okay, so if any one of you wants to log out, you're most welcome. Okay, otherwise please bear with me for another 30 minutes. Okay, now coming to this answer of a 55-year-old elderly diabetic came with complaints of purulent urticaria. The words are important. Okay, the words are important. Just see what they are saying. That he comes with purulent urticaria, severe otalgia, hearing loss. Given below are the otoendoscopic finding. Images from Scotland. Okay. Now they are asking what is the diagnosis, what is the most common organism responsible, and name 2 nuclear scans which you will be doing for this thing. So the answer for this is
Malignant otitis externa.
yes. This is either malignant otitis externa, or you can answer skull base.
Okay.
Skull base osteomyelitis. The organism responsible for this is Pseudomonas. Okay. So in case it happens in the exam that they ask you what is the organism responsible and you don't know the answer, take a safe bet on Pseudomonas. Don't leave it blank. Okay. Don't leave it blank. Okay. Now over here, what all things extra are there? That there are few scans which you should know about. I'll just go about them in a brief. Otherwise, you can refer to Scotland. It mentions everything in detail. So the first is you should remember about technetium 99 scan. Okay. यहाँ पे आपको जो 2-3 points which you have to remember that this is 100% sensitive. They'll ask you what are the scans, what is the advantage, what is the disadvantage. This is 100% sensitive, positive in malignancy. Okay. And apart from that, specificity is low. Okay. Though it is sensitive 100%, but its specificity is low. And second point over here, what you should remember that it cannot differentiate between active infection and bone remodeling. Cannot differentiate between active infection and bone remodeling. ठीक है, तो क्वेश्चन क्या पूछेंगे? टेक्नीशियम 99 स्कैन का एक एडवांटेज एक डिसएडवांटेज. एडवांटेज में आप यू कैन इजीली पुट इन व्हाट इज दैट दिस इज 100% सेंसिटिव. डिसएडवांटेज दैट बिकॉज इट कैन नॉट डिफरेंशिएट बिटवीन एक्टिव इन्फेक्शन एंड बोन रिमॉडलिंग, तो आप इसको फॉलोअप के लिए या मॉनिटरिंग रिस्पांस के लिए यूज नहीं कर सकते. ठीक है. नाउ कमिंग टू द सेकंड थिंग, सेकंड इज योर गैलियम 67 citrate. Okay, यहाँ पे two things you have to remember. Only important is that this can be used for monitoring the response of your treatment, whatever you are given. ठीक है. And because what happens is that जो गैलियम होता है, गैलियम का जो अपटेक है, this normalizes as the disease gets better with disease resolution. ठीक, then comes your C में one another name you should remember, indium. ठीक है, what is this? This is a labeled leukocyte scintigraphy. And fourth, this is your SPECT. Full form of SPECT. बताओ 10 दिन बाद. हाँ, सिंगल फोटोन एमिशन CT. ठीक है, कंप्यूटर टोमोग्राफी. Now, coming to this, identify the scan. I'll enlarge it for you. Identify the scan, full form of SPECT. Mention one advantage and one disadvantage of technetium 99M scan. So the answer is indium labeled scan. ठीक है, this image is from Scott Brown, likely to be asked. ठीक है, though I have not seen it till now, but it will form a very good DNB OSCE question if it is asked. ठीक है. Okay, so we know the full form of SPECT also. We know the advantage and disadvantage of technetium scan also. 2-3 things you should remember about this skull-based osteomyelitis. Generally, elderly people में देखा जाता है. Diabetes, immunocompromised history is there. The otalgia जो है, you might ask you that how is describe the otalgia of malignant otitis externa. So this is nocturnal, generally nocturnal, deep pain. Deep, and what word they use is lancinating, sharp shooting pain, and the pain is disproportionate to the clinical findings. ठीक है? And otalgia is also the most common symptom also. No. Coming to the third thing, a 50-year-old male came with complaints of otalgia and discharge. Okay, no cranial palsy on examination. Given is the MR scan of the patient, diagnosis and name of the staging. Okay, again the image is from Scott Brown. I'll enlarge it for you. Okay, this is an important question. This is squamous cell carcinoma of the canal. Okay, diagnosis आपने बता दिया. Name of staging used. Can somebody help me with this? Try करो भाई. Yes, the answer is Pittsburgh staging. Please remember only the name. ठीक है, उसके अंदर जाने का जरूरत नहीं है. The answer is modified Pittsburgh staging. ठीक है, they might even ask you for the treatment also. For treatment now you'll have to refer Scott Brown. Okay, so this is basically your temporal bone resection. This can be extended or lateral temporal bone resection. Please read about it. Read about temporal bone resection. There is a very beautiful diagram in which which mentions ki what all things you will remove in extended temporal bone resection and what all you will not remove. Okay, so that can be a very possible question in part of your viva also, table viva also, and your might be of OSCE also. Okay, now this is one very commonly asked scan for you. Okay, so they'll give you something like that, है ना? ABCD को block करके, and they'll ask you what is A, what is B, what is C, what is D. Okay, so A is one of the very important structure for us. The answer is pterygo maxillary fissure. ठीक है. B, somebody will like to take a try. B क्या है? B is your foramen ovale. ठीक है. C, carotids, easy going. D will be your any of your ossicles basically. ठीक है. D incus हो गया. E is your facial nerve. And F is your petroclival synchondrosis. This was something which I don't think why they'll include for you. बाकी पर पता होने चाहिए आपको. ठीक है. The answer given over here. ठीक है. Images from Radiopedia. Like if you want, you can see it in dichrome also. Okay. Okay. Moving ahead. They're saying to you to identify the condition over here. Okay. The image is from Scott Brown. There are 2-3 things which can come like this. Are you able to appreciate this? Answer is your high riding jugular burr. Okay. Similarly, for this, after this, please check once how this corner septum looks like. ठीक है, this is not corner septum, but एक बार corner septum का CT भी देख लेना. ठीक है. Now coming to this again, these images are all from the skull base section of from the Scott Brown. That's why they are coming in continuation. Now over here, what they are saying is, see it once. Basically, this is the finding, nothing else. Okay, this is the finding for your fistula over the semicircular canal. Okay. Now again, moving ahead to one of the important topics for you. This much year old male patient came with history of RTA. Now complaints of watery nasal discharge on examination. On examination, you see that facial palsy is also present. Now there is CT scan given of the patient. What is the classification for the temporal bone fracture? I hope every one of you can see this is the fracture line which is running. Okay, so they're asking you what is the classification for the Now again over here you can see this is the transverse type of fracture. This is the indicative of that. So there are two types of fracture basically. Okay, please remember it. Facial nerve is your bread and butter. Each and everything about facial nerve, starting right from your topodiagnostic tests, जिसमें आपका पूरा शर्मर की इमेज से लेकर के इलेक्ट्रोगस्टोमेट्री, everything from here to its branches, to its cores, 1 2 3, then ये आपका जो इनॉग और ये वाला सेक्शन है फॉर फेशियल नर्व दैट. ठीक है, व्हाट विल बी द फाइंडिंग ऑन ये. देन कम्स योर बेल्स पैल्सी, एंटायर थिंग अबाउट बेल्स पैल्सी, रामसे हंट सिंड्रोम, ओनली two syndromes you should remember. Now causes of bilateral facial nerve palsy. ठीक है, recurrent facial nerve palsy, very important viva question. ठीक है, ये हो गया. इसके बाद ट्रॉमा टू फेशियल कैनाल, टेम्पोरल बोन फ्रैक्चर, जिसमें what we are discussing right now, and management of facial nerve palsy. Okay, and after this there are two gradings which are there for your facial nerve. One is the House-Brackman grading. They might even ask you give one other name other than House-Brackman. So the answer is Sunny Brookmans. Okay, this is given in Scott Brown. Okay, this is the newer classification which is used, that is the otic capsule involvement. Though it has been you would have read it multiple number of times, I will request it again to read it because this is important. Okay, and they will at least for till you pass your exam. Okay, another name they can ask you by the name of Kelly and Tammy. It's also called as Ulrich classification. This one, ULRICH, Ulrich classification. Okay, so please go through it. It's important. Okay, so this is important. Now, what is this? So this is basically corner septum. Okay, this is corner septum. What is the this is also called as persistent
Petrosquamous.
Yeah, Dr. Ujjwala. Petrosquamous suture, that is and you should be careful about it during the mastoid surgery, because if you think that the antrum has been reached, so the surgery will be incomplete. Okay, this is a sign which has been you all remember it since times. The name of this sign is Kennedy's nipple. Okay, this is a very old question. What's the full form of SPAL? Can somebody take a try? Artery ligation. अब आज आपका दो काम है. One, watch video of SPAL on YouTube. एक दूसरा steps of SPAL. ठीक है, कि how you locate the artery behind the middle turbinate and then how you ligate it, because this is a potential GIF or video based question. ठीक है, so please read about it once. This is important. Okay, again going through this. So over here I'll just like to take this this is your anterior lacrimal crest सपोजिटली ये इससे 24 mm पीछे यू विल बी हैविंग एंटीरियर एथमोइडल आर्टरी, इससे 12 mm पीछे यू विल बी हैविंग पोस्टीरियर एथमोइडल आर्टरी, एंड इससे 6 mm पीछे यू विल बी हैविंग द ऑप्टिक नर्व. Okay, so this you should remember. Okay, जैसे ही optic nerve comes into your picture, please go through the scans of HCT PNS scan involving the optic nerve. Okay, so all the four things I shared the video, I think 2 days prior, that pentagon of sphenoid which they form. So you should be ready, easily identifying the optic nerve, the onodi cell, the foramen over there, है ना? So that you should be easily identifying. You shouldn't I'll say don't mess on that. It's very important. Please see it again. Now it's again repeatedly asked question, ठीक है? But this is Delano's classification only. Okay, this is the onodi cell which they are talking about. This is the significance of onodi cell. Okay, all the named cells, ठीक है? All the named cells, that is your onodi, halar, agar nesai. ठीक है, तो ये तीनों को देखना है. Very high chances that you can get one of them in your exam. ठीक है, on identification, and what all the important sections are there, we have been repeatedly discussing about that. Please go through it. Okay, so 2 classifications apart from that, that is your Delano classification, then Quiroz classification. Okay, then there is one classification, I'm forgetting the name, which tells you the attachment of the uncinate process. Yes, Risberg classification. ठीक है, तो these are the 3 classification which you should be like ready in your mind. कि अगर PNS से पूछेंगे तो generally these are the routine questions. Like अगर ectop is coming तो then it's okay. ठीक है, but routine में यही आएगा. ठीक है, moving ahead. Quiroz हो गया, हाँ, very favorite, very important. ठीक है, and definitely you will get it in some form or the other. ठीक है, identify the highlighted structure, what structure passes through it, what is Wernicke syndrome. Okay, so there's no fun in telling, the answer is jugular foramen. So before we proceed further to this question, 2 things for you. Out of the whole skull base, please go through 2 things in depth. One is your jugular foramen, and second is your superior orbital fissure. Okay, right from the anatomy, that is handwritten diagram. They might ask you to draw the diagram also. Then CT of it, 2. Then boundaries of it. This came in one of my exam, that what are the boundaries of superior orbital fissure. So I remembered it how to see it, but वो exam में तुक्का लगा करके लिख के आना पड़ा था. ठीक है, boundaries, then contents, and anything named which is there out of it. So let's see what is there for. Okay. So this jugular foramen is basically divided into 2 parts. That is your pars nervosa. This is the thing which is getting nervous, like every one of us during the exam time. This is pars vascularis. ठीक है, pars vascularis is a chill guy. He only has 10, 11 and jugular bulb with them. But this poor nervous guy, since he is a small fellow, ठीक है, and what all does it contains? It contains 9th cranial nerve, it contains the cavernous sinus, it contains the inferior petrosal sinus. ठीक है, so because of all these things, this is getting nervous. Okay, so please remember कि what is there in nervosa, what is there in vascularis. Okay, this is as per your Scott Brown. ठीक है, now coming to the syndromes which they ask. There are 2-3 syndromes, that is Wernicke and Villaret, and then Collet-Sickert, you should remember. So in this, basically 9th, 10th and 11th, all 3, sorry, 9th, 10th and 11th. ठीक है, तो ये तीनों nerve जाएंगे. They might ask you what will be the presentation of the patient in such a syndrome. So when 9th nerve will go, there will be loss of taste in the posterior 1/3 of the tongue. 10th चला गया तो बहुत कुछ होगा. You can एक बोलेंगे गैग रिफ्लेक्स चला जाएगा, एंड 11 चला गया तो शोल्डर में जो आपका श्रगिंग रिफ्लेक्स होता है दैट विल गो. ओके, सो दिस इज अगेन one image from for your superior orbital fissure. Please go through it in case if you have not gone through it. Annulus of Jin कैसे बन रहा है, what is left behind, like after it, कौन सा nerve बाहर है, which nerve is inside. Okay, so here this is from Ken Hub. the image, this is good enough, you can enlarge and see over here. ठीक है, please go through it if you have not remembered it. रट्टा 5 वाला चीज है, please याद कर लो इसको, if you have not remembered, this table should be ready in your brain. ठीक है, what is passing through which place. If you have confusion in any specific thing over here, please let me know. ठीक है, now again I was waiting for this is what are the boundaries of superior orbital fissure. ये मेरा आया हुआ क्वेश्चन है जो शायद मेरे से गलत हुआ था. What is Rochon Duvignac syndrome. ठीक है, तो सुपीरियर ऑर्बिटल फिशर के बारे में बात कर रहे हैं. बेसिकली दिस इज द आंसर. व्हाट इज द एनाटॉमी, दिस इज द मीडियल सुपीरियर इंफीरियर एंड लैटरल पार्ट. ये रटना है. आई apologize, I could not find any mnemonic for it, but please remember it. It is not that difficult. And coming over here, the superior orbital fissure syndrome, this itself is known as Rochon Duvignac syndrome. ठीक है, so this all things will happen. Okay, so go through it. And the clinical presentation we have seen. Okay, there is one more question. What is the difference between superior orbital fissure syndrome and orbital apex syndrome? Can somebody take a try?
So the vision loss is there in orbital apex.
Yes, that's a correct answer. In orbital apex syndrome, there is vision loss. बाकी मोटा-मोटा सेम ही रहता है. So this is अगर एक like if they ask you for one mark, so this should be the first line that you should answer. That this is like vision loss is one of the main thing. Here they have again this table is from Scott Brown only, and they are like collectively they have mentioned all the three syndromes, that is Collet-Sickert, Wernet, Villaret. These three you have to remember. Don't forget. Now over here this is the repetition of question. That identify the diagnosis. What is the sign? What is the contrast use? This image is from Scott Brown, but the same has been asked in the main exam also. Okay, the diagnosis is your vestibular schwannoma or CP angle tumor करके लिख सकते हैं, but you should write vestibular schwannoma. Please don't write acoustic neuroma. Okay, as per Scott Brown, what they mention is vestibular schwannoma. ठीक है, and of the side also you have to mention if possible. ठीक है, अगर confusion हो रहा है तो मत लिखना. Second is what is the sign? This is called as ice cream cone sign. The contrast use is gadolinium. Over here only there is one named curve. Please remember it. The name of this curve is Nelson-Allen curve, which shows you the growth of intrameatal and extrameatal vestibular schwannoma. There are two named curves which you will find in your while preparing for this thing. One is the Nelson-Allen curve. Then second will be your Kaplan-Meier curve. Please remember it. Along with it, please read the hazard ratio. Okay, if you don't get the answer, again do message me. You can message me multiple number of times, n number of times till 25th. Okay, and there is a possibility that I might have forgot or like I would not have been able to get back to you. Please again उसी को forward back करके कि इसका मेरे को आंसर भेजो करके ना, do keep sending it. ठीक है, until you clear your this exam. Okay, again this is the repetition where I was completing the entire skull base from your Scott Brown. This image is cyber knife. I'll repeat the questions because you would have got bored by these questions till now. These are routinely being asked. The questions are, the first is difference between SRS versus SRT. The answer goes as कि SRS में there is only one dose, while there is in SRT there are multiple sittings required. Okay, then they will ask you what are the difference between cyber knife versus gamma knife. Okay, go about it. Then three questions over here. I'll just see enlarge and tell you the table. SRS is recommended for tumors which are please see over here. I'm reading here. Generally, I don't read from text, but please see it. SRS is recommended for tumors less than 3 centimeters diameter. They'll ask you what will happen if you give SRS. पहला क्वेश्चन तो यही हो गया कि SRS के लिए what is the size of the tumor which you say. So the answer should be less than 3 centimeters. Second is if you give it more than 3 centimeters, so there will be basically obstructive hydrocephalus. Second question, what is pseudo progression? This is pseudo progression. मतलब after giving SRS there is transient enlargement of the tumor followed by stability or even regression. So this is pseudo progression. Third question, कि कितना डोज देते हैं, तो 12 से 13 ग्रेस आर गिवन टू द मार्जिन ऑफ ट्यूमर. इनिशियली इट वाज 16 ग्रेस. चौथा क्वेश्चन, इसके बाद अगला आता है. दिस टेबल इज फ्रॉम स्कॉट ब्राउन. आफ्टर दिस पेज देयर इज समथिंग कॉल्ड एज RION. ठीक है, दिस इज रेडिएशन इंड्यूस्ड ऑप्टिक न्यूरोपैथी. प्लीज गो थ्रू इट. दिस कैन बी आस्क्ड टू यू. Now again, moving ahead, this scan is of your neurofibromatosis. You can see the vestibular, you can see the CP angle tumor, both side vestibular schwannoma. The drug which they use over here is bevacizumab. Please read about it. The mechanism of action of bevacizumab, that it is a VEGF inhibitor, that is vascular endothelial growth factor. One thing for you, that please don't use any short form in the exam. अगर पूछते हैं mechanism of action तो पूरा लिखना है. Please don't write VEGF, anti-VEGF. Full form you should write. Okay. Condition, you know what is the screening protocol basically. See over here. This is the bevacizumab which they are using. Screening protocol, they have mentioned it here. This one. ठीक है. It should begin at 10 years of age. First line. Second, MRI screening every 2 years for those under 20 and 3 years for those under 30. Over here, after bevacizumab, there is one distant cousin of bevacizumab by the name of cetuximab. Please read it. This is important. Okay. Okay. Now this is the same image of jugular foramen from another angle given in Scott Brown. So just to complete the list, I included these two images. I didn't feel them of being any importance, but please read it. है ना? आपका exam है, तो you have to read everything I'll say. Because if something comes out of the syllabus, everyone will say, yeah, this is stat only. But generally, from a student's point of view, this is a difficult thing. But at least have a look at what they're trying to say over these two scans. Okay, this is a superior view, and this is the inferior view. Sorry, from this side. Okay, these are the named syndromes. Repeated. Now, two things I'll just mention here only. I'll need 5 minutes from you guys. One thing is regarding the ward rounds. Okay. So I got one query from two of you, that what they will generally, how these ward rounds go about. Okay, how the ward rounds go about. So in ward rounds, generally they might even take you to ward also if they have some patient over there who they have kept specifically. This depends entirely upon what institution you have gone to give your exam. It is not sacrosanct कि ऐसा ही होगा type से. It's not sacrosanct. They might take you to the ward, or they might you might be sitting over there only, and they'll keep 4 tables. Okay, and they'll whatever patients they have, they might keep bring the patient. They might give you one type of A4 size of paper in which all the details of all the details of patient are given, and basically they'll screw you by taking your viva only. Okay, so generally what happens, if you are lucky, then you'll be able to know what patients they have admitted in ward for the ward round. You might be able to know that. Okay, it depends upon God where your center comes. Okay, so let's hope for that. I'll let your center come. After that, we'll talk about it. Okay, so one thing they can do like this also. Second, what they can do is they can this will be, I'll say, table viva only. So what they can do, they can again make you run through 4 tables. Okay, now see, you go for the exam marks distribution. The 100 marks are for OSCE, 100 marks are for the long case. Remaining 100 marks they have to divide into 2 ways. Either they can give you word rounds of some marks, 60 and 40 what they mention in the DNB जो उसका PDF they have sent out. The 40 marks they'll be giving for word round and 60 for the table viva. Over here they can break it for short case also. They might give you something like you go to one table and here you pick up a chit and they say there is a patient of unilateral nasal obstruction. Now think for 2 minutes and they'll take your viva on this thing. So everything will go towards nasal obstruction viva. Same goes over here. If there is a patient of swelling over the right side of neck, okay, and take history from the patient for 2 minutes and then you'll start your viva. So everything will go about how do you examine the swelling, what are possibilities. You can either take the viva to the cups thing, you can take it to cervical lymphadenopathy, whatever you know about, accordingly they can happen. And same goes for the table viva. They can even give the radiology. They can keep the CT scan or something like that. So for CT scan, I got a query from one of you, so I just wanted to answer. The details you all know. How to start the CT scan. Just a minute, just take a minute. Like suppose here they have mentioned the films. This can be a possibility. They can give you the films, or there can be a projector screen जहाँ पे detail of that dichrome में चल रहा होगा. So how you have to start basically, just read it over here. यहाँ पे पढ़ना है. Details of patient are generally given. ठीक है, they are given. So if the details are given, so you have to say, sir, this is a लाइक अगर NCCT है तो फुल फॉर्म नॉन कॉन्ट्रास्ट CT स्कैन ऑफ पेशेंट so and so 35 years old of which region of paranasal sinuses. One, we can see these cuts. अगर जो भी आपको दिख रहे हैं axial cuts है या coronal है या sagittal है, जो भी है you have to speak कि sir we are seeing the coronal scans and I would like अगर film if they are mentioning the film so sir I would like to take it from I would like to answer from the left upper end of the film. So from here you have to start. So this should be your opening line. Directly don't jump upon ki sir HRCT temporal bone. No. So you have to answer like this sir, this is a high resolution computed tomography scan of patient named so and so, aged so and so of the temporal bone region. We have been provided with the axial scan or the coronal scan, and these are the findings. You can start from one end. Okay. So table viva mein it can be radiology, it can be plus minus osteology. I generally have not seen, but depends upon your institution exactly saying in what places you are going. Then there will be instruments. Okay, there will be instruments. Okay, and then apart from that, I don't think anything else. Okay, so they can keep plus minus anything for your viva basically. Okay, so you have to read or whatever you have read, like you have to revise. I'll not say read now. You have to revise whatever you have been reading for the past 2 months till now. Okay, so over here again I rest my case. Okay, please any positive or negative things from your side, and I'm like open for you. Please let me know. Okay, so next we'll be having on CA larynx. Then OSCE head and neck and mock exam final wala, so which you were requested for mock exam on 18th. Okay, so that mock OSCEs again 20 OSCEs same level we'll be having on 18th of February, right? And this CA larynx I'll just tell you 14 February in case like कुछ निकलता है तो फिर 15 को कर लेंगे है ना. I'll message you a day prior only. Okay, so read about CA larynx. Some of you might get that also as long case, but 90% will be getting CM's commerce. आप लोगों से बोलता हूँ भाई, हाथ जोड़ के बोलता हूँ, please read again and again. It shouldn't be कि out of 100 marks के commerce में तुम लोग 50 के लिए struggle कर रहे हो. This should not happen यार. ठीक है, you should at least be 55 to 60 plus आना चाहिए. So if you lag behind somewhere, यहाँ पे कहीं टेबल वाइवा में 1 or 2 टेबल वाइवास goes wrong or God forbid your 1 or 2 OSCEs like goes haywire, so you should not worry. तुम्हारे पास 10-20 numbers का cushion होगा यहाँ से. ठीक है, तो this will be the cushion factor. Work hard on your long case. Still you have 2 full weeks. ठीक है, in case you get stuck, कुछ issues होते हैं, please let me know. I'm here for long case, but please clear it properly. If you will clear it, the chances of you clearing the exam will get manifold increase. Chalo, all the best, bhai. Bye, good night.